Okay. So it's starting recording now. So thank you guys for reminding me. So this is we were talking about the main difference in pediatrics versus adults for cardiac is that most of the time when kids have heart diseases, they're born with it. They have a congenital heart defect instead of it being something that they acquire. So this first slide goes over some key things that might lead you to believe that they have a cardiac problem, usually that they're born with. So not gaining weight well, failure to thrive, being blue or pale. They might have some visual pulsations in their neck, tachypnea, tachycardia, clubbing of fingers is kind of a later sign. This is something that you see in chronic hypoxia. Something that's very, very specific to infants is that they have a hard time feeding. They tend to fall asleep or not have the energy to feed, or maybe some increase in sweating. So like I said, most of the time people are diagnosed with their heart defect in utero or shortly after birth, but there are some occasional cases where the kids they go through, several months or maybe even years of life before they're diagnosed. So congenital heart disease is the most common type of heart defect. And there's lots of different factors that can lead to congenital heart disease: genetic, maternal, maybe taking medications in uterus, environmental factors. It's always important to remember that the fetal circulation is different than the postnatal circulation. So even though they can have a problem growing after they're born, they tend to develop, other than their heart problem, okay in utero, because their fetal circulation compensates for their heart defect. So this is just kind of going over the fact that the congenital heart defects are the most common sort of defect that you see that are congenital, and almost always they require surgery. So this is just your basic view of the heart. And I really think it's important that you always, when you're thinking about a defect, that you remember what the normal blood flow through the heart is. So if you look the blue side, this is the right side of the heart. So you're going to get blood that comes from the superior vena cava and the inferior vena cava, and it drains into the right atrium. And then it goes to the right ventricle. It goes out the right ventricle to the lungs. So this is your pulmonary artery here, and it branches off to go to each lung. And then on the other side of the heart, on the left side, the pulmonary veins drain blood to the left atrium, and then it goes down to the left ventricle and it goes out the aorta. So you should always be thinking, whenever you hear that the patient has a defect, like where in the heart is the defect and how is that changing the normal flow of blood that you would see in someone that doesn't have a defect. So this one, I didn't mention this. So there's two general categories. So cyanotic and acyanotic. Who thinks they know what it means to have a cyanotic defect? What do you think that means? Do you think they have a normal oxygen level? Bluish. Okay. So do you think they have a normal oxygen level or no?
No.
Okay. Is it low or high?
It's going to be low.
It's going to be low. And then there's going to be the acyanotic. So they have a heart defect, but they don't necessarily have an oxygen. Very good. And then in addition to that, we kind of subdivide it. So you can have defects that cause an increase in pulmonary blood flow, that obstruct blood flow in some way, or that decrease pulmonary blood flow. So whenever we're going to get to, the different defects, but always think about what is the defect causing and how is it changing the normal flow of blood. And then there's a term that we talk about in cardiology. It's a shunt. So shunt is just the flow of blood between an opening of the heart. So there's three places where you're likely to maybe have an opening. There's what's called the ductus arteriosus, which would be here where the pulmonary artery and the aorta cross. So sometimes there's an opening here. There can be an opening in the top atria, that's called an atrial septal defect, or there can be an opening in the ventricle, and that's called a ventricular septal defect. So when we talk about a shunt, we're referring to blood flow that goes through one of those holes. And it's abnormal. So it's not normal to have a shunt, but we talk about shunts a lot when we talk about cardiac defects in children. And shunts always go from a high pressure to a low pressure. So they're going to go down the path of least resistance. This slide here shows you, the normal blood flow and then how it changes for the defects. So this is what we talked about, a couple slides ago. It's coming in, the deoxygenated blood is coming in the right atrium, going to the right ventricle, and then going to the lungs. And then oxygen-rich blood from the lungs comes back to the left side and then goes out to the body. So then here we have an atrial septal defect, which is a hole in the top two chambers. So you can see this is a left to right shunt. It comes into the oxygenated blood, comes into the left atrium for the lungs, and then some of it goes back over to the right side instead of going out to the body. So what do you guys think? If you have a shunt at the atrial level because you have an atrial septal defect, does that increase your pulmonary blood flow or decrease your pulmonary blood flow?
Decrease.
It's going to, okay, we got one for decrease. So it's going to come from the left side and it's going to go to the right side. And ultimately the blood on the right side goes to the lungs. So does anyone else think maybe it might increase the pulmonary blood flow? What do you think?
Yeah, it's going to increase. It's going to increase it.
It's going to increase it because it's increasing the blood that's on the right side, and the right side is what goes to the lungs. Do you think you're likely to have hypoxia if you have an ASD? No, because right, you don't have any obstruction to the lungs. So you're getting more blood flow to the lungs than you need, but that's not going to cause hypoxia. Very good. So then this one here is pretty much, it's very similar, except the hole's on the bottom. So the hole's down here in the ventricle. So it's going to come, blood from the lungs to the left atrium to the left ventricle. Most of it's going to go to the body, but since there's a hole here, it's going to go over to the right side. So it's going to be similar. Is this going to increase or decrease your pulmonary blood flow?
Decrease.
You think it's going to decrease? Why would it be different than the atrial septal defect? Atrial septal defect increased your pulmonary blood flow.
Because it's at the bottom instead of the top of the heart.
Okay.
Those down there.
Okay, but it's still going over because the blood flow
Okay,
to
I
the
see
lungs
what you're
comes
saying,
from the
yeah.
right ventricle, yeah. So it's still going over to that right
It
ventricle.
increases.
All right, very good. So these three are kind of similar. ASD, VSD, they put the PDA down here at the bottom. I'm just going to put this slide up really quick. The PDA is here where the pulmonary artery and the aorta cross. For the sake of this diagram, they put it down here. But it's going to be the same thing where it goes left to right. And so it's going to increase your pulmonary blood flow. This one here is one of the obstructive defects, and it's called coarctation of the aorta. And this is just a narrowing. So you see the blood coming out the left ventricle to the aorta, and then it has a hard time getting out because of that narrowing. So this doesn't increase your pulmonary blood flow at all, but it is an obstructive lesion. And this one here we'll talk about more, tetralogy of Fallot. I want you to see something here. This here has this narrowing going to the lungs. So do you think this has increased pulmonary blood flow or decreased or no change?
It's going to be a decrease if it's narrowing.
Decrease, right, because you have this narrowing here. Very good. So this one, we're going to talk more about tetralogy of Fallot, but there's four things. There's the VSD, there's the narrowing to the lungs, there's right ventricular hypertrophy, and then there's what's called an overriding aorta. So the aorta is misplaced. So this is one of the more complex ones, but it does cause decreased pulmonary blood flow. And we'll talk about it in more detail because it's a more common defect and there's always questions about it on your tests. So we went over these. I'm not going to go over this again because we talked about which ones increase and decrease pulmonary blood flow. So this is kind of, we talked about acyanotic, they don't tend to be blue, and then cyanotic, then they are going to be blue when you guys got these right. So all of these, VSD, ASD, PDA, these three, they increase your pulmonary blood flow. They do not cause cyanosis, and coarctation is that narrowing of the aorta. So it's harder to get blood out of the left side, but it doesn't cause hypoxia. And these on this side, these cause the babies to be blue. The one that is most common in this category is the tetralogy of Fallot. So that's the one that we're going to go over again in more detail. So this slide is just reminding you that not every baby that has a heart defect has a problem with oxygen levels. So just because we want to check it, but that's not going to be, the main thing that you look at to make a decision about whether or not you think they have a heart defect. So restrictive, that's one of the subcategories. The most common in the restrictive is going to be your coarctation of the aorta. When there's narrowing here, you see it in this little picture, there's narrowing of the aorta, so it's harder to get blood out to the body. So, so generally speaking, the narrowing of the aorta causes decreased blood flow to the lower part of the body. So do you think if you have a coarctation of the aorta, your blood pressure is higher or lower in your legs? If you're having a problem getting blood to the lower part of your body.
Lower. So it'd be lower.
It'll be higher.
Going to be lower. So when you have, so that's one of the sort of classic findings for a coarctation of the aorta is a blood pressure discrepancy between the arms and the legs. So you can have hypertension in the arms, but then low blood pressure in the legs. It can lead to congestive heart failure because it's having the heart's having to push against that narrowing, and they can also develop endocarditis if they don't have surgery earlier in life. So sometimes this is one of those defects, the coarctation, sometimes it's not that narrow, and kids will be 4, 5, 6. I've even had teenagers before they were diagnosed. So this is, ideally they're treated earlier in life, but these symptoms that you're seeing here, you're more likely to see them when they're kind of that late diagnosis, so that they don't get picked up early in life. So in terms of the decreased pulmonary blood flow, tetralogy of Fallot, pulmonary stenosis, these are both, they have a narrowing from the right side of the heart out to the lungs. So that's why they cause decreased pulmonary blood flow. And since they have the decreased pulmonary blood flow, they can cause that cyanosis. So tetralogy of Fallot, this is one that I told you was more complicated. This is certainly one that you need to remember and sort of remember the four elements that have to be present for it to be considered a tetralogy, and think about how that's going to affect the blood flow. So the pulmonary stenosis, we talked about that. That's going to be decreased pulmonary blood flow because it can't leave the right side of the heart to go out to the lungs. And then right ventricular hypertrophy, that's just because the right ventricle is having to push harder against that stenosis. The overriding aorta, that just means it's just part of the defect, but it just means the aorta is pushed to the right side. And then a ventricular septal defect, there's a hole down at the bottom between the left and right ventricle. So you see cyanosis, it gets worse as they get older. They tend to squat. So this picture here of this kid that's squatting, that's pretty common when they have tetralogy of Fallot. They tend to have feeding problems, failure to thrive, and they can have polycythemia. Does anyone know what polycythemia means?
Too much blood in the cells.
Very good. Too many red blood cells. Okay, so red blood cells carry oxygen. So why do you think someone with a tetralogy of Fallot would have too many red blood cells?
Hyperventilation, maybe. Much heavy breathing.
Yeah, so it's the body's way of compensating to bring more oxygen. Since they don't have enough oxygen, they produce more blood cells to have more oxygen carrying capacity. It's a compensation that the body does for the chronic hypoxia. So there's, something, a hypercyanotic spell is also called a TET spell. Happens most often in the first 2 years of life, and they become blue, they develop respiratory distress, and they can pass out. And when this happens, you need to know to put their knee into the chest position. So this is a common thing that you're going to be tested on. So if they have a hypercyanotic episode, the nursing intervention is to put their knees into the chest. So this child here in this picture here, she's doing it on her own. She's squatting. If you're taking care of a patient that has a TET spell, you're just going to physically push their knees into the chest. And what that does is it forces blood back to the heart. So it increases the venous return to the heart, and then some of that blood will then go to their lungs. and it'll improve their hypoxia. So this is, this is specific to tetralogy of Fallot, where they have that narrowing and they can get like upset and they're crying, and then they can have a tet spell. And the thing that you do as a nurse is you push their knees into their chest. And this is the baby. If he was sitting up, usually when you're taking care of a kid and it happens, they're going to be lying down, but you get the idea. Knees to chest. So a lot of kids are diagnosed in utero, but you can get an EKG, an echo. Sometimes they need a cardiac catheterization. So there's very specific sort of complications that can be, associated with having congenital heart disease. Sometimes, if they have the polycythemia, they're in greater risk for thrombosis. Sometimes they can, have iron deficiency anemia just because they don't want to eat. They can have bacterial endocarditis, chronic hypoxia. Some defects are going to be what are called ductal dependent, so that these patients require prostaglandin E therapy before their surgery. So just kind of keep an eye out that there's lots of very specific complications that can be associated with a child having a congenital heart defect. So there's a couple that are mixed that I'm not going to spend too much time on because I know they're not heavily tested. So I'm going to focus on the ones that are the most heavily tested. So hypoplastic left heart syndrome is probably the most severe cardiac defect. So tell me about the word hypo. Does hypo mean large or small?
Small.
Small. So hypoplastic left heart syndrome, the left side of the heart is too small. So there's two valves on the left side of the heart. There's the mitral valve, which is the valve in between the atrium and the ventricles. There's the aortic valve, between the ventricle and the aorta. There's the ventricle, and then there's the aorta. So in hypoplastic left heart syndrome, it's across the entire spectrum. Everything on the left side is too small. So they don't get adequate blood flow to their body because the left side, which is the pumping chamber, is too small. So this is a ductal dependent lesion where this duct between the pulmonary artery and the aorta has to stay open because you end up stealing blood from the pulmonary artery to get mixed in with your systemic circulation. So if this duct closes, then they don't get enough blood flow to their body. So this is one of those defects where they're going to require prostaglandin E to keep this duct open here between their pulmonary artery and their aorta until they have their surgery. So many times when babies have heart defects, they're in a specialized unit. They have nurses that have specific training for cardiology, but there are some basic things that you need to know. You're obviously going to be monitoring their vital signs, monitoring their circulation and their pulses, doing neurovascular checks, keeping a strict eye on their eyes and nose, their feeding, their activity, etc. So, fatigue, not eating well, having a hard time breathing, not growing well, and both increased heart rate and respirations. Sort of all of these things together might make you think that they have a heart defect that wasn't diagnosed. So, they need more emotional support and care. A lot of times they need additional nutritional support. They might need higher calorie formula because they can't eat as much because they don't have the same energy reserve. They tend to be cared for in specialized units with nurses that have more advanced training in cardiology. So acquired heart disease, this is going to be something that happens after birth. It's not because they were born with it. And then heart failure is just a general term. It's like a decrease in cardiac output necessary to meet the demands of the body. So heart failure can happen because of like a viral infection or a myopathy, or patients can have sepsis, they can have untreated hypertension, severe anemia. These things can all lead to acquired heart disease. Like I said, in kids, it's not that common. Usually kids have congenital heart disease. So this bit here, the right and the left, I think you guys studied this in med surg. So, you should be able to recognize the difference between right-sided heart failure and left-sided heart failure. So what can you tell me about left-sided heart failure? What are some common presenting symptoms of left-sided heart failure? What do you hear when you examine your patient that has left-sided heart failure? What sort of
Crackles
abnormal, crackles where? In the lungs?
in the lungs.
Yeah. So you're going to have this problem, right, where it doesn't pump out the left side, so then it backs up into the lungs. And then what sorts of problems do you see with right-sided heart failure?
Is it edema, swelling?
Very good. So they can't get the blood out from the right side to their lungs, so then the veins drain into the right side, and so it backs up and they get the edema. So, the body is always going to try to compensate for whatever's going on. So when you're not having enough blood flow, you're going to have peripheral vasoconstriction, which can make your hands and feet feel cold. And you might also have tachycardia and tachypnea that's trying to compensate for the fact that you don't have enough cardiac output, which means you don't have the same oxygen delivery. So, like I said, I think this is probably covered more thoroughly in your med surg class, but it's going to be, the same sort of thing. Kids can develop congestive heart failure, so you're going to be having to think about how you would treat that. So unloading whatever ventricle, whether it's right or left, that has the problem, you're going to be using things like nitrates and Lasix as vasodilators, or to get fluid off, oxygen. So I don't think you need to spend a lot of time studying congestive heart failure in the pediatric class, because it's something that we don't really necessarily see that often in pediatrics, but I would be aware that it does happen, and the treatment is really very similar to, it's the same as it is in adults. So if you have a child in congestive heart failure, there are certain things that you need to pay attention to. So what would happen that you would suspect it? So they might have tachycardia at rest. They might not be able to finish their feedings, unusual sweating, dyspnea, so having a hard time breathing, and sudden weight gain. So I would certainly remember this, because it doesn't happen very often. Kids don't normally develop congestive heart failure, but you certainly need to be aware that it does happen, and you need to remember the symptoms so that you could identify that might be the problem. So the general goal is to reduce the workload of the heart, maintain their oxygenation, make sure they don't get an infection, and then treat the underlying cause. So you want to, if you have a kid that has congestive heart failure, you want to give them time to rest. So you're going to bundle your care, and then, adjust their feeding schedule around their sleep schedule and their crying schedule. So you're not feeding them when they're irritated, you're not waking them up to feed, etc. Small frequent meals, they might need oxygen. You're going to make sure they take their medication, and intake and output is really, really important when you're dealing with somebody that has heart failure. So we're going to move on and talk about, this is one of the main causes of acquired heart disease in children, which is rheumatic fever. So has anyone heard of rheumatic fever?
Yes.
Yeah. What precedes it? Like, what type of infection do they normally have? And then they get rheumatic fever. Strep throat. So this is why it's really, really important that strep throat is treated. So it's an autoimmune reaction to a strep throat infection. And there's some very specific sorts of symptoms. They can end up, with chorea, which is this uncontrolled muscle movement, this erythema marginatum, which is this weird looking rash. They can have problems with their joint swelling and inflammation around the heart. So there's a couple of different things that, are pretty specific to rheumatic fever, but it does happen after a strep throat infection. So that's why it's really, really important that they take their antibiotics and they finish the full course. So if they're diagnosed with rheumatic fever, then they have to take antibiotic therapy for 5 years. So this is something that they're going to be treated for a long, long time after they've developed rheumatic fever. So it's what's called the Jones criteria, which is, you have to have, it's up here. I think you should just recognize the name of it. Jones criteria is how you diagnose rheumatic fever, and they have to have 2 major or 1 major and 1 minor criteria plus a history of strep throat infection to be diagnosed. I don't think that you have to memorize all the different what's major and what's minor, but I would recognize that there is a specific Jones criteria that is used to diagnose rheumatic fever. So the main way that you prevent it is making sure that they are tested and treated appropriately for their strep throat, and that they take the full course of their antibiotics. So another thing that can happen, sometimes kids can have high blood pressure. Obviously, it's more common in adults, but it can happen in kids. So if it's primary, that means they have high blood pressure without something else causing it, or it can be secondary. So like a problem with your kidneys, an endocrine problem could all lead to hypertension in a kid. What do you think you do if you have primary hypertension in a 12-year-old? What is the first intervention for primary hypertension in children?
Medication,
Okay, if it's not medication, what would it be?
diet,
Diet and exercise. So almost always in kids, you're going to start with diet and exercise modification if it's primary hypertension, and then you would move on to medication if that didn't work. And if it's secondary, you need to treat the underlying cause. So, obesity, stress, etc. This can all lead to hypertension in kids. If it's primary hypertension, it's probably related to obesity and lack of exercise. So you start with diet and exercise modification, and then you move on to medications. So this is just kind of reiterating that fact. Things that you can do for primary hypertension, primarily moderate exercise, improving their diet. So in kids, we have more and more problems with obesity. So we also have to worry about the cholesterol level. Does anyone know which one is the good one and which was in the bad one when we talk about HDL and LDL?
HDL is the good one, LDL is the bad one.
Very good. So the LDL is the one that's going to deposit plaques, cause you to have plaque buildup, and the HDL actually carries cholesterol to the liver for excretion. So you want to have, a higher ratio. You want more HDL to LDL. So this is, a lot of information on this slide, but it's mainly that you need to be aware that children can have hyperlipidemia. You need to be potentially checking their cholesterol levels and giving them dietary education, et cetera. It would be very, very unusual that you would start any sort of statin or cholesterol medication in a child. You would start with diet modification. So there is a disease called Kawasaki disease that you need to be aware of. Kawasaki is a cause of acquired heart disease. So Kawasaki disease, it's not really understood well what causes it. It could be a reaction to an infection, an autoimmune reaction. Sometimes people think it could be related to like the shampoo that parents use to clean their furniture and their carpets. It's not contagious, so it doesn't spread from one person to another. So it's not totally known why kids develop Kawasaki's. But what it is like vasculitis. So they have inflamed red, inflammation of their blood vessels. So I'm going to show you the picture here. These are some common findings in Kawasaki's. So they have like the bright red strawberry tongue, the red lips, the red eyes. They can have the spotty rash, the dry cracked lips. So Kawasaki's is a vasculitis, and it causes all of this sort of red inflammation. And it also can cause inflammation of your coronary arteries. So that's why it can cause acquired heart disease, because it causes inflammation of the coronary arteries. So it's one of those diagnoses of exclusion. It's not, they don't normally get diagnosed with Kawasaki's right off the bat. So it's associated with a high fever, 40 degrees Celsius, 104 degrees Fahrenheit, that doesn't really come down, you know, with antimicrobials or Tylenol or Motrin, and the fever lasts for more than 5 days. And then I showed you those pictures. They're all inflamed and red. So this is the classic presenting picture for Kawasaki's, and this is kind of what they look like when they come in. So this is one of the, this is pretty much the only time that you are going to give aspirin to a child who has a fever. So I think I remember telling you that salicylate, this is the aspirin family. So why do you, yeah, it kind of says it here, but why do you think you would give aspirin to this child?
In the blood?
In the blood. So think about it like somebody that has an adult that has a problem with their coronary artery. They're frequently on an anticoagulant. So this is, you know, the coronary arteries are the blood vessels that deliver oxygen to the heart, and they can have coronary artery problems because of the Kawasaki's. So they usually start them on aspirin, and they may end up on Coumadin, which is also warfarin. So this is the only time that you're going to give aspirin to a kid that has a fever, is when they're diagnosed with Kawasaki. And they're also given this IVIG, which is the IV gamma globulin. So it's a lot of supportive care. These kids feel pretty terrible. They have really high fevers. They don't want to eat. They don't want to drink. They're super irritable. So it's a lot of supportive care and teaching them, supporting the mom and the dad. So we don't really have time to do the whole respiratory presentation, but I want to point out some key things. So I'm going to ask you guys some questions. So who has heard of croup?
Yes.
I have
Yes.
it now, I think.
You have it now? Okay.
I've heard of it.
Yeah. What kind of symptoms? What do people sound like when they have croup?
Congested,
They sound like me.
Oh, yeah. Yeah. So kids tend to have what they call a barky or a seal-like cough. So it's very common that they'll refer to as a barky cough. And what's a nursing intervention for croup?
Is it antibiotics?
So they frequently are going to need antibiotics. It could be both viral or bacterial, but this is the one where you want them exposed to humidification. So you'll either have the parents have a humidifier or take them into a bathroom that's steamy. So if they have that barky cough and you're doing like phone triage in the clinic, if they're okay, they're able to talk, they don't really need an emergency room right away, you'll have them inhale some steam, some humidified air. And then asthma is a common condition that you're going to see in kids. There's a lot of nursing sort of questions related to like proper inhaler use, and making sure they're using a spacer and teaching them how to use the spacer, et cetera. Making sure that, you know, they're taking their medication as prescribed. Pneumonia is going to be the lower airway. So that's the main illness of the lower airway. That's almost always going to be treated with antibiotics. And has anyone heard of epiglottitis?
Yes.
What can you tell me about epiglottitis?
Some with the tongue.
Okay, so it's going to be, it's an upper airway obstruction. So it's right around your vocal cords. And this is one that 100% you have to recognize this is a medical emergency. These kids come in, they can't breathe. They're leaning forward, they have tripod posturing, they're drooling, they can't speak because their vocal cords, that whole area of their upper airway is inflamed, so they can't get air in and out. So when you see epiglottitis, you always think prepare for intubation or prepare for emergency tracheostomy. This one is bacterial. They tend to have very high fevers, and they're really sick when they come in. And if you suspect epiglottitis, you also have to be thinking, okay, we're going to probably intubate. And then kids also, it's not uncommon for them to have a tonsillectomy and adenoidectomy. Has anyone had their tonsils out? No? Known anyone that had their tonsils out?
No, but my son got his adenoid shaved down twice.
Yeah, but they didn't remove them?
No, they were just shaved. The second time they didn't grow back.
Okay. So if they actually have them removed, they'll be in the hospital at least overnight. And something that you need to be aware of is that sometimes they'll swallow all the time. And that could be a sign that they're bleeding at their surgical site, because the surgical site is going to be in their throat. So you won't necessarily see bleeding, but if they're swallowing, they could have a small amount of blood that's accumulating back there. So you need to be concerned if your patient's had a TNA, a tonsillectomy, adenoidectomy, if they're swallowing all the time. It's painful, so they're going to need like cool fluids, but you don't want to do anything that's irritating. You're not going to give them like soda pop or orange juice because they've just had surgery down there. I think those are the kind of the main things. Okay, and then bronchiolitis. You guys have all heard of RSV. So RSV bronchiolitis, most dangerous in kids under the age of 2. And there is an immunization for RSV, but it's only given to high risk or premature infants. So not all babies get the RSV immunization, but there is one that they can give to babies that are high risk. All righty, so you guys are troopers. We're gonna do a quick Kahoot here, and then you guys are gonna be free to go. So let me pull it up, and if you have any questions, let me know, and I'll make sure to send out the PowerPoints so that you can print them. Let's see here. Okay. So a positive throat culture for group A strep would be treated with what? Tylenol and fluids, a strep immunization, penicillin for 10 days, or penicillin until the sore throat is gone. Yeah, very good. So penicillin until for 10 days. If you just do till the throat is gone, that won't adequately treat it and they can still get problems, recurrent strep infections, maybe even rheumatic fever. So which congenital heart defects cause increased pulmonary blood flow? ASD, VSD, PDA, tetralogy of Fallot, aortic stenosis, pulmonary stenosis, coarctation of the aorta, pulmonary stenosis, VSD, VSD, aortic stenosis, tricuspid atresia. Very good. These are the three that you need to remember that increase pulmonary blood flow. They're the shunts, and they're a left to right shunt, from the left side to the right side. So a child swallows frequently after a tonsillectomy and adenoidectomy. What might this indicate? Vomiting, pain at the incision site, bleeding from the surgical site, or a sore throat from post-nasal drip. Yep, this is the one. This could be bleeding from the surgical site. So you need to pay attention to that if you have a post-op TNA. So what should the nurse explain to the parent of a child with exercise-induced asthma? No, I don't like this question. We're going to skip this one in just a second. So this is another one we're going to skip. Sorry. I don't think you guys have enough time for all of these. So I'm going to go to the ones that I know that we studied. So I'll put this in class and you can look at all of them if you want. So which fluids are appropriate for a 5-year-old with asthma experiencing dyspnea and fluid loss? Carbonated beverages, iced fruit juice, room temperature water, or cold milk? All right, so it is going to be your room temperature water. You don't want to give anything that's super cold because that can cause bronchospasm, and you don't want to do anything annoying like a carbonated beverage. So just some good room temperature water is the best option. So why are parents who use dry powder for inhalers for the treatment of asthma instructed to rinse the mouthpiece? Prevent discoloration of the tooth enamel, prevent candidiasis, which is thrush, prevent or protect against irritation of the oral membranes, or to prevent halitosis, which is bad breath. Yeah, so this one we didn't really get into, but they can develop thrush if they're not keeping their equipment clean. So how long after a smoke inhalation injury are patients at greatest risk for pulmonary edema? 72 hours, 4 hours, 18 hours, or 2 hours? All right, so several of you got this right. Impressed. So 72 hours, you should remember this. Peak inflammation for anything. They've had a head injury, they could have that inflammation within 72 hours. They fall, they hit, they bruise their arm, you can have that peak inflammation within 72 hours. So that peak window after an injury for inflammation is always 72 hours. And that's true also for any sort of smoke injury, lung damage. Which initial intervention will the nurse suggest to the parents of a child experiencing a barky cough? Bring the child directly to the emergency department, take the child outside to the cool air, use a humidifier, or take the child into a steamy bathroom, or have the child drink plenty of fluids. Yeah, so this is the croup, which is you suspect croup when they say barky cough. This is one where you need some humidification. So what findings are expected when measuring the blood pressure on all four extremities of a child with coarctation of the aorta? It's going to be lower in the arms than in the legs, higher on the left side, higher on the right side, or lower in the legs than in the arms. Yeah, very good. So this is one where they don't have the good perfusion, even their femoral pulses might be weaker, their pulses and perfusion in their legs. So you expect them to have lower blood pressure in the legs. Why do children with tetralogy of Fallot favor a squatting position? Decreases arterial blood flow away from the heart. It's a resting position when the child has a tachycardia. It increases the venous return of blood back to the heart, or increases the workload of the heart. So yeah, it pushes blood back to the heart, which is going to ultimately help resolve their TET spell. Very good. So which comment by the parent of a 1-month-old would concern the nurse about a possible congenital heart defect? He sleeps all the time, he tires out during feedings, he's fussy for several hours a day, or he's always hungry. So yeah, this is the big one. He tires out during feedings. This is a classic sign of congenital heart disease in a baby. So through what does the infant born with hypoplastic left heart syndrome acquire oxygenated blood? An atrial septal defect, the patent ductus arteriosus, a ventricular septal defect, or the closure of the foramen ovale? Right, so this one was a little bit trickier. This is the patent ductus arteriosus. That's the duct that stays open between the pulmonary artery and the aorta. So if they have a PDA and they don't have any other heart defects, that's a problem. But if they have hypoplastic left heart syndrome, they need that duct to stay open to get the blood out to the body. And does anyone remember the name of the medication that they give babies to keep that duct open? So it's called prostaglandin. It's abbreviated PGE, and it keeps this duct open. That's why they give it to some babies if they have heart disease. So a child recovering from rheumatic fever needs to receive monthly injections for 5 years of what medication? Prednisone, penicillin, Benadryl, or Zosyn? So it's penicillin. So they're going to get antibiotics for 5 years after they're diagnosed with rheumatic fever. So the nurse should prepare for emergency intubation when caring with the child with what diagnosis? Asthma, bronchiolitis, epiglottitis, or Kawasaki disease? Very good. This is epiglottitis. It's something you definitely need to remember is considered a medical emergency. How do you treat primary hypertension in a child? Encourage moderate activity, give Lasix at bedtime, encourage a high salt diet, or refer to an endocrinologist. Very good. This is what you're going to start with: diet and exercise, and if it's a kid with primary hypertension. So an infant with a heart failure and failure to thrive will likely have what diagnostic test first? An electroencephalogram, a cardiac catheterization, electrocardiogram, or an echocardiography? All right, so yeah, they'll probably start, an echocardiography is another way, it's an echo. So they'll probably start with the echo if they have a heart murmur. All right, last one. What is the difference between HDL and LDL? HDL reduces the buildup of plaque. LDL increases the risk of plaque buildup. They are the same thing. HDL is a protein, LDL is a lipid. HDL is higher in cholesterol than LDL. Yeah, so HDL is a good one. It reduces the risk of plaque buildup. So reduces your coronary artery cardiovascular risk. All right. Tweezy, who's Tweezy?
It's Twisty and it's me, it's Pam.
Okay, Jesse, very good, you guys. So Husto, just at the end of nick of time here. So after class, it takes me a little while to process the lecture, etc. But I will upload the video, I'll email you the PowerPoints, and I'll give you the Kahoot. And then please remember that we have to meet as a group to go over your test scores. So I can't give anyone's test scores. It'll be Saturday because the last class is on Friday. Does anyone have any questions? Nope. And then please remember you have quiz 4 next week. All righty. You guys have a good day.
Thank you.
Thank you.
Bye-bye.